We are honored to have both Dr. Phil Teal and Dr. Andrew Penn speaking with us today. They have been the champions in the development of telestroke here in BC. Dr. Teal will be presenting from Vancouver, and Dr. Penn, who is here with me in Victoria, will be presenting from here. So we'll make the presentation a little bit more challenging, and you will not be actually seeing Andrew, unfortunately, but you will be hearing his voice. During the question and answer period, we'll be going to voice activated, and at that point then, when the person is speaking, you'll then see them on the screen, hopefully, if everything goes well. So we expect that the presentation will run for about 40 minutes, and so there'll be plenty of time for questions after. We have the video conference up and running until 1:15. So before we get going, I'd just like to quickly introduce our speakers. Dr. Penn completed degrees in neurophysiology and medicine at Cambridge University in England, then did specialty training in neurology at UBC. He did an MRC fellowship in MR spectroscopy of brain and muscle and went on to become associate professor in the departments of neurology and public health sciences at the University of Alberta. In 1999, Dr. Penn helped to establish the Stroke Rapid Assessment Unit and the Centre for Stroke Research in Victoria. He presently holds a Heart and Stroke Foundation CIHR grant examining TI incidence and intervention on Vancouver Island. Dr. Teal, who will be the first speaker, is an internationally recognized expert in stroke. He is the director of the Vancouver Hospital and Health Services Centre Stroke Program, chair of the Canadian Stroke Consortium, and a board member of the Canadian Stroke Strategy. His clinical focus includes stroke prevention, acute stroke management, neuroprotection strategies and planning, organizing and managing clinical trials. Dr. Teal is also the chair of our Telestroke Working Group here in BC. So I just want to thank them both for taking the time to come here today and to share with you their experiences with moving telestroke forward here in BC. And now I'm going to ask Phil to begin. I'll pass it over to you, Phil.
Thank you, Helen. Good afternoon. I hope everyone can hear me. Jen, if you're online, can you mute the Victoria VGH mics for now? So, good afternoon. I'm going to start off talking to you about telestroke. And the first thing I'd like to reassure you is that actually doing a telestroke consultation is technically a whole lot easier than it is to arrange this teleconference today. Both Andrew Penn and I have had several cases and a fair bit of experience with it, and it really is a technology that works well when it's directed from one site to another. So these are my disclosures. I'd like to point out to you that we will be talking about the use of TPA, which is one of the thrusts of telestroke, is the assessment and treatment of patients for thrombolytic therapy with TPA. TPA is fully licensed in Canada by Health Canada for use in acute ischemic stroke within the 0 to 3 hour time window, and the application is in place for the current scientifically demonstrated expanded time window of 3 to 4.5 hours. And this expanded time window has been endorsed by the Canadian Stroke Consortium, the Canadian Stroke Network, Heart and Stroke Canada, as well as a number of other authoritative bodies, and it is embedded into the Canadian best practice guidelines for treatment of acute stroke patients in Canada. So we've already demonstrated this slide, but these are some of the websites that you can access to review this talk and to get further information. So our agenda this morning is to talk about the use of telemedicine in the assessment and treatment of acute ischemic stroke patients, let you know exactly where we're at this point in time in BC and what lessons we've learned and where we hope to go in the very near future, and hopefully integrate many of the sites that are participating in this teleconference today. So first of all, an issue about the impact of stroke. Stroke is really a devastating disease. The carnage of stroke in Canadians is evident in all of our hospitals on a daily basis. In Canada, we see 50 to 60,000 new stroke patients a year, 7,000 or 8,000 in British Columbia, during the course of this teleconference, several more Canadians will have had a stroke. Of course, it's a hugely expensive disease. The very conservative costing of stroke care in Canada is $3.6 billion. This is based on old data, and certainly the current costs far exceed that. Why? Longest length of stay of any disease entity. Stroke patients stay in hospital for a long time. They get transferred to rehab care after that. Many of the individuals required long-term institutional care, and there's a huge loss of productivity, not only for the individual, but stroke is a disease that impacts the entire family and caregivers. So as far as a cause of death, stroke is the third or fourth leading cause of death in Canadians. And to put that into perspective, stroke kills more women in Canada every year than heart disease, more women in Canada every year than breast cancer, more men in Canada than either AIDS or prostate cancer. So it is sometimes a fatal disease, but more important than probably the tombstone count is the severe disability that arises from stroke, and also the fact that stroke and vascular dementia is the second leading cause of dementia, which is of course epidemic in our country. And as our population ages, the incidence of stroke survivors, physical and mental impairments, and vascular dementia will increase amongst our citizens and family members. So if you take all comers with stroke, about 3/4 are going to either be dead or disabled. The disability, of course, is variable from mild to severe, but as this slide demonstrates, about 50% of patients will have major motor deficits, hemiparesis. A third will be unable to ambulate without the use of aids. A quarter need assistance with activities of daily living. Almost 20% of stroke survivors will have major language and communication problems. Post-stroke depression afflicts more than a third of stroke patients and is often under-recognized. And over a quarter of stroke survivors require long-term institutional care. These are strokes that we call life-altering strokes. You were one day enjoying your life and the next day you're wrecked or institutionalized, and it's a huge impact on the life of the individual, and as I said, it extends to the entire family. So this is the published guidelines from the Canadian Best Practice recommendations. These recommendations are published in the CMAJ, and they're now being updated as we speak this year, but our current recommendations in Canada is that all patients with disabling ischemic stroke symptoms who are eligible to be treated within 4.5 hours from symptom onset should be immediately evaluated, their eligibility for TPA determined, and TPA be provided if they fulfill the treatment criteria.